Hello and welcome to today's edition of GP Notebook podcasts. My name is Dr. Hannah Rosa. I'm a GP working in the northeast of England and a member of the GP Notebook education team. Join us for a whole range of bite-sized topics tailored for those working in primary care, perfect for your daily commute or when you're out on a morning stroll. You can tune in to us on all leading podcast platforms, and don't forget to like and subscribe so you don't miss an episode. And if you enjoy what you hear, please consider leaving a review. You can stay connected with us on X at GPnotebook for podcast updates and much more. Lastly, check out the new GP Notebook website for podcast show notes with additional resources and to register for study groups. In this episode, I'm going to explore the updated clinical guideline published in December 2024 from NOGG, the National Osteoporosis Guideline Group, on the prevention and treatment of osteoporosis. This guideline is crammed full of really useful information for us working in primary care. And in this podcast, I'm going to share with you 10 learning points that I took away from it that have changed my clinical practice, with the hope that it will also benefit you. At the end, there'll also be a quick quiz so that you can test your knowledge. For my first point then, I thought that I'd start by asking you, how big a problem are we dealing with here? How many women do you think sustain one or more fragility fractures in their lifetime? 1 in 4, 1 in 3, or 1 in 2? I personally was shocked to learn that it is in fact 1 in 2 women, and for men, 1 in 5. Now, whilst not all fragility fractures are in people with osteoporosis, the guideline does quote that the predictive value of bone mineral density for a hip fracture is at least as good as that of blood pressure for a stroke. In other words, the lower the bone mineral density, the greater the risk. Osteoporosis is usually defined as having a bone mineral density T-score of less than or equal to -2.5. But remember that there are also other risk factors for sustaining a fragility fracture, with one of the biggest being the risk of having a fall. And so, when assessing fracture risk, as well as calculating whether we should be checking bone mineral density, we should also be considering if there is anything that can be done to reduce the falls risk. For my next learning point, we all know that the UK's population is ageing. It therefore follows that we're going to see more people developing osteoporosis and sustaining fragility fractures. In the next 5 years, do you think that there'll be a 5%, a 10%, or a 20% increase in the number of fragility fractures? Well, if changes are not made to current practice, then it is predicted that there'll be a 19.6% increase in the number of fragility fractures by 2030, a point which hammers home the fact that changes do need to be made. So, for my third point, I'd like to address who we should be offering a fracture risk assessment to. There are different tools that we can use to assess fracture risk, but NOGG mainly focuses on FRAX, which was launched by the University of Sheffield in 2008. And so it's the one that I am also going to be referring to in this podcast. To get us thinking further about who needs an assessment, let's think of some cases. In which of these patients would you consider doing a FRAX assessment on? A 55-year-old man with epilepsy? A 60-year-old lady with asthma? Or a 51-year-old man who has had bariatric surgery? Well, the answer is all of them. NOGG state that a FRAX assessment should be performed in any postmenopausal woman or man aged 50 or over with a clinical risk factor for osteoporosis or sustaining a fragility fracture, and neurological conditions, lung diseases, and conditions associated with intestinal malabsorption are all classed as risk factors. In fact, the guideline lists over 50 risk factors, and many of them may well be conditions that you hadn't previously associated with requiring a FRAX score. For point number 4, I'd like to highlight that the NOGG guideline applies to postmenopausal women and to men aged 50 years and older. So what about premenopausal women and men younger than 50 who sustain a fragility fracture? Well, osteoporosis is uncommon in this group, and therefore when a fragility fracture does occur, these patients need to be thoroughly investigated for a secondary cause of osteoporosis, such as underlying primary hyperparathyroidism or celiac disease. There also needs to be careful consideration of treatment options, and caution is advised when prescribing bone protective therapy in women of childbearing age. A specialist referral is therefore usually required for this group of men and women. For point number 5, I'd like to start by asking you if you have ever used a FRAX score for a different country, other than maybe by accident. You may well have noticed that when you go onto the FRAX website, you need to select a continent and then a country to access the calculation tool you require. This then leads to the question, if you, for example, work in the UK, are there any times when you should not use the UK FRAX tool? Well, the answer is yes. When using FRAX in individuals who have moved from another country to the UK, regardless of their ethnicity, NOGG advises that we should use the FRAX model for their country of birth, if it exists. This is because individuals retain the risk characteristics of the place where they were born. So, if you're assessing a 61-year-old lady who has moved to the UK, having previously spent her whole life in Sri Lanka, then we should be using the Sri Lankan FRAX calculation tool, not the UK one. For point number 6, I'm going to focus on steroids. Bone loss and increased fracture risk occurs early after the initiation of oral glucocorticoids. NOGG advises us that medium doses, for example 2.5 to 7.5 milligrams a day of prednisolone, are the assumed requirement by FRAX. If a patient has been on a medium dose for 3 months or is anticipated to be on this dose for 3 months, then we should select yes for the glucocorticoid option on FRAX and use the result given. However, what if you have a patient who is taking a higher dose, a dose greater than 7.5 milligrams daily, and is likely to be on this dose for more than 3 months? FRAX reminds us that with steroids, as with alcohol use and smoking, the higher the exposure, the greater the risk. So is there any way of taking this into account? Well, NOGG advises that for patients who will be or who have been on a higher dose of steroids for 3 months or more, then we should select the glucocorticoid box, but then alter the result to reflect the increase in risk. How do we do this? Well, we should increase the major osteoporotic fracture probability by 15% and the hip fracture probability by 20%. Simple. But what about if a patient is taking a lower dose, a dose of less than 2.5 milligrams per day of prednisolone, and they will be for at least 3 months? Well, for this scenario, then we should still select yes for the glucocorticoid option in FRAX, but again, we need to alter the results given to reflect the decrease in risk. In this case, we should decrease the major osteoporotic fracture probability by 20% and the hip fracture probability by 35%. Once you have made these adjustments, you will then be left with 2 new percentages that differ from those on the FRAX website, and so your new results won't match with the graph that is then provided to guide you as to whether a DEXA scan is needed or not. To overcome this, you can use the manual data entry tool on the NOGG website, and this will then generate a new graph for you based on your adjusted results. I have put a link to NOGG's data entry tool in the show notes. Now for point 7. If you're thinking that needing to adjust your results for high and low steroid doses sounds like an awful lot to remember, well, Frax have just launched their new tool, Frax Plus. And this allows you to add in some extra information and it then adjusts the results for you. On Frax Plus, you can select whether a patient is on a low, medium or high dose of steroids. But there are other factors that you can adjust for too. These include the number of previous falls that the patient has had in the previous year, the duration of time that they have had diabetes for, and the type of previous fractures that they have had, as well as how long ago they were sustained. However, to use Frax Plus more than 5 times, you need to purchase credits. And you still need to put your new values into the NOGG manual data entry tool to generate the intervention graphs. It is also worth noting that on the Frax Plus website, they state that they recommend that it is not used for clinical purposes. So back to using basic Frax and getting the calculator out. For point number 8, I'd like to highlight a few problems that I have with the graph that is generated by NOGG once you have done a Frax calculation. The graph will have a low risk green area labelled Give Lifestyle Advice, an intermediate risk amber area labelled Measure BMD, and then 2 red areas, one high risk labelled Treat and the other very high risk labelled Consider a Specialist Referral and Treat. So, do patients who have a result in one of the red areas need a DEXA scan? Well, NOGG advises that men and women with high and very high fracture risk, in other words those in the red areas, should have a DEXA scan if a baseline measurement is needed against which to compare future bone mineral density measurements. And I'd argue that the only way we're going to know if the treatment that we're giving to a patient is helping is by having this baseline. I feel that it would therefore be better if the high risk red area, instead of just being labelled as Treat, was labelled with Treat and Measure BMD. Now, for the patients in the very high risk area, the main reason that NOGG advises that they should be referred to a specialist is because many of these patients would benefit from an anabolic drug, such as teriparatide. Now, these drugs are believed to work better if given to patients who have not previously used oral bisphosphonates. To make all this clearer, I would therefore like if the very high risk area was labelled with Consider Specialist Referral, Measure BMD and Treat if there's going to be a delay in the patient seeing a specialist. To be fair, NOGG do give all this advice if you scroll down beneath the graph, but I feel it would be better if it was on the graph itself. For point number 9, a new exciting update in the 2024 NOGG guideline has been regarding HRT. HRT is now recommended as a first-line treatment option in younger postmenopausal women aged 60 years or less with high fracture risk and a low baseline risk for adverse malignant and thromboembolic events. NOGG highlight that we should discuss continued use of HRT after the age of 60 years with the patient based on an individual risk-benefit analysis. And when HRT is discontinued, we should reassess fracture risk and consider an alternative treatment if indicated. Lastly, my final point, point 10, is all about vertebral fractures. Most vertebral fractures do not currently come to medical attention and thus remain undiagnosed. Moderate or severe vertebral fractures, even when asymptomatic, are strong risk factors for subsequent fractures at the spine and other skeletal sites. A vertebral fracture assessment should therefore be considered in high-risk individuals. Who are these high-risk individuals, I can hear you ask? Well, NOGG states that a vertebral fracture assessment is indicated in postmenopausal women and men aged 50 and over if there is a history of height loss of 4 centimetres or more, kyphosis, recent or current long-term oral glucocorticoid therapy, a BMD T-score minus 2.5 or less at either the spine or hip, or in cases of acute onset back pain with risk factors for osteoporosis. The next question is then, how do we do a vertebral fracture assessment? Well, it is either by using a lateral lumbar and thoracic X-ray or by requesting a lateral spine DEXA scan. The DEXA option delivers a significantly lower radiation dose whilst performing comparably to traditional X-rays. However, remember that a DEXA scan is done with the patient laying flat and so generates anterior-posterior views of the spine, not usually lateral ones. Right, now time to check your knowledge with a few questions. Oliver is a 51-year-old gentleman with COPD. He comes to see you as his sister has just had a hip fracture and he wonders if he should be checked for osteoporosis. Would you A, advise doing a fracture risk assessment such as FRAX, or B, advise him that he doesn't need a fracture risk assessment unless a parent has had a hip fracture? The answer is A. But it's not the family history that qualifies him for a FRAX assessment, as NOGG only lists a parental history of hip fracture as being a clinical risk factor, but NOGG do list COPD as being one, and so this should trigger a fracture risk assessment. You proceed to use the FRAX score online. What is the first thing that you should check? A, his age, B, if he takes steroids, or C, his country of birth? The answer is C. NOGG state that we should use the FRAX model for the patient's country of birth, and thus this needs to be checked before we enter any other data. Looking back through Oliver's notes, you notice that over the last 12 months, he has had 4 5-day courses of 30 milligrams of prednisolone for exacerbations of COPD. This works out at about 1.6 milligrams a day. Should you A, ignore this as it's not a regular daily dose, B, take it into account by just selecting the glucocorticoid option in FRAX, or would you C, select the glucocorticoid option but then adjust the fracture probabilities, decreasing the hip fracture probability by 35% and decreasing the major osteoporotic fracture probability by 20%? The correct answer is C. As he is having on average less than 2.5 milligrams of prednisolone per day, then NOGG classes it as a low steroid dose, and so the final probabilities need to be decreased. This may now lead you to ask, but what if he's taking inhaled steroids every day? Should this also be considered? Well, NOGG don't address this in their guideline. However, they do on their frequently asked questions page. And they state that the evidence is currently inconclusive. In patients with COPD, a large meta-analysis of randomised control trials did confirm an association between exposure to inhaled glucocorticoids and an approximately 1.3 times increased risk of fractures. In other meta-analyses, the relationship was not seen at all or was only present, also at approximately a 1.3 times increased risk, in those on high dose of inhaled glucocorticoids. Pragmatically, higher doses and continuous use of inhaled glucocorticoids should be borne in mind when deciding on investigations and management of bone health in such patients. Well done to those of you who got all 3 questions correct. And this brings us to the end of this podcast. However, the new NOGG guideline does contain a lot more information. If you would like to learn more, then I go into the guideline in even more detail in Study Group 1, which is running throughout the year. To find out more, please visit the GPnotebook website. In this study group, I discuss the other clinical risk factors which should prompt a FRAX assessment and how the FRAX score can be adjusted further to take some additional risks into account. I also review the use of FRAX versus Q fracture, discuss other clinical investigations we should consider, before diving further into management, who we should refer and what the future may have in store. Thank you so much to those of you who have already joined me when this study group launched in January, and I hope to see some more of you there later in the year. Thank you all for listening today. I hope that you found this podcast helpful and that you've learned a few extra nuggets of information. As always, all of the links to resources I've mentioned will be in the podcast notes at GPnotebook.com. And we'd be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments or ideas for future podcasts. Right. Based on the 19.6% increase in fragility fractures we're predicted to see in the next 5 years, I'm off to buy shares in pants which have added hip protection. Goodbye.